Hey everybody, welcome back to another episode of QuickSTEPs. Today we are going to be covering immunology and rheumatology and seeing how that content is presented in board style format. Before we begin, I would just like to mention, if you want to support the channel, feel free to subscribe, like, or comment. Anything and everything is appreciated, and if you're going to leave a comment, maybe just tell us any specific content that you want us to cover. All right, with that being said, let's dive on into some questions. So let's just practice the method here, and we want to apply it to every single question, no matter if it's long or short. Sometimes if it's really short, you could just do, the one or two lines there and then try to get to your answer. But let's just get in the habit here. So I'll read the second to last line with you guys, then go to the question itself, and then go to the answer choices, and then we could read over the whole thing, okay? So the last two lines, it begins with basic metabolic profile shows calcium level is at 1.1 milligrams per deciliter. The child is prone to infection according to his mother. What part of the lymph node is expected to be atrophied? A, medullary sinus, B, paracortex, C, follicle of cortex, D, medullary cords, E, capsule. Now we can read the whole question looking for key words. So, a 6-year-old boy has involuntary muscle spasms in his extremities. Physical examination shows easily removable white plaques with surrounding erythema on the oropharynx. And then we already read the rest, so we know that he has a low serum calcium. And all these lab values are actually provided in the little lab section. You can just click on the labs and it'll come with a drop-down list. And you just look for calcium and it'll tell you the normal. This is low. And the child is prone to infection according to his mother, so there's some sort of immune problem going on. Not surprising, as this is the immune section. Okay, so let's just go through the answer choices. We have medullary sinus. What cells reside in the medullary sinus? So you should be saying macrophages. Macrophages or histiocytes largely occupy the medullary sinuses. How about the paracortex? T cells, right? Paracortex contains T cells. The follicle has those germinal centers. That's where the B cells activate. And then we have medullary cords. And the medullary cords is where plasma cells, B cells, and some macrophages also exist. And then the capsule, what cells reside there? Yeah, right. It's just dense, irregular connective tissue. Okay, so that's a little bit of a trick. They're trying to make you think maybe you don't know what cells are there, so you might choose that in a panic. Never panic. You know most of the content, and if not, we have test-taking strategies that could get you there. So what is this question really asking? Well, we know there's an immunodeficiency because prone to infection is quite literally just another way of saying immunodeficient. And he has easily removable white plaques. Is a hallmark characteristic for thrush, also known as oral candidiasis. Right? It's a superficial fungal infection. It's actually normal flora to a capacity, but this is just overgrowth because your immune system is not functioning properly. So what has immunodeficiency with low calcium levels? Okay, you should be saying DeGeorge syndrome, right? DeGeorge syndrome. So why do they give us muscle spasms? Well, anytime you have low calcium, you could go into a state of tetany or involuntary muscle contractions, right? Because you get closer to the depolarization threshold. This is a very common way that the boards test DeGeorge syndrome. DeGeorge syndrome is chromosome 22q11.2 deletion. I would just memorize chromosome 22. And all that really translates to is it's a failure of the third and fourth pharyngeal pouches to develop. And the third and fourth pharyngeal pouch contain the thymus and the inferior and superior parathyroid glands, respectively. So if you have failure of the parathyroid glands, you're not going to have that PTH being released, right? The parathyroid hormone. And the parathyroid hormone is the thing that melts bone to release calcium into the bloodstream. And it also helps reabsorb calcium in the kidney, but that's not really the focus too much for this question. All you have to know is, since you're missing it, you're going to have low calcium levels, and the low calcium levels lead to spasms. And quite frankly, you don't even need to know that. You just need to know that it's DeGeorge syndrome and what's actually wrong, the thymus. What is the thymus responsible for? Well, the thymus is important for maturation of T cells. Right? So if you don't have a thymus, if it's completely absent, which is the case in DeGeorge syndrome, you will not have T cells in circulation. And if that's the case, then you sure as hell are not going to have a strong immune system. So this is an interesting way to ask it, but where in the lymph node would T cells reside? Where do we know that they reside? That portion where T cells reside in the lymph node is going to be atrophied or smaller. So which portion is that? Well, we talked about it already. T cells reside in the paracortex. So the paracortex is the part of the lymph node that is affected in DeGeorge syndrome. All right, so we're off to a strong start. Let's keep the momentum going with this next question. I want you to do this question on your own, and then we'll talk about it before I show you the answer. So this question is all about acute graft rejection, and you do have to know a little bit about it in order to get this question right. And there is a slight nuance to this question that I think it's very helpful to learn. So what's the cell that's responsible for acute graft rejection? It's mainly T-cell mediated, right? There's CD4 response and there's the CD8 cytotoxic response. That's the whole thing with acute graft rejection, is it's T-cell mediated, both CD4 and CD8 T-cells. So I bet you a lot of people probably chose CD4 because they were like, oh, helper T-cell most likely, that's usually the right answer, boom, we're going to go with that. Well, in this case, you would be wrong. And I know the rest of you, the ones that are currently watching this, all chose CD3, right? Because CD3 is for all T cells. That includes both helper and cytotoxic. So CD3 is on every single T cell, whether or not CD4 or CD8 are present. Right? So helper T cells have CD3, and cytotoxic killer T cells have CD3 as well on them. Okay, and just for completeness sake, let's talk about CD14. Well, that's found on macrophages or histiocytes. So CD14 is found on macrophages. How about CD19? CD19 is found on B cells. So CD19 is found on B cells and plasma cells. How about CD34? So CD34 is slightly lower yield, but I would definitely recommend knowing it. It's that is the surface marker for hematopoietic stem cells. All right, good job on that. Let's keep the momentum going with question 3. As this is a short question, I'm going to read it with you, and then we're going to talk about it, and I'll let you choose an answer, then we'll discuss the answer choices, okay? So, a T helper cell located in the peripheral circulation is bound to a cell through a class II major histocompatibility complex. It does not receive co-stimulatory signals from the bound antigen presenting cell. What is the fate of this specific T helper cell? A, it will be activated and able to perform its effector function. B, it will undergo class switching. C, it will undergo anergy. D, it will release granzyme. E, it will undergo clonal expansion. So what do you guys think? Okay, so let's say you don't know the exact answer to this. Let's do what we would normally do anyway. Let's do process of elimination. Okay, so let's start with A. It will be activated and able to perform its effector function. Well, we know T cells, when they're activated, could perform an effector function. So we might have to hold on to that one if we assume that it's enough to just activate it without a co-stimulatory signal. How about B? It will undergo class switching. Do T cells undergo class switching? No, that's only for B and plasma cells, right? It will undergo anergy. So what's anergy? Anergy is different than apoptosis. The cell is not undergoing self-regulated destruction. It just kind of stays there, and it's permanently lost its effector function, right? It's essentially doing nothing. It's still there. It's not trying to kill itself. It just does nothing and it circulates. How about D? It will release granzyme. So we know CD8 positive cytotoxic killer T cells do release a granzyme, and that, and porphyrins, and they poke holes in the membrane and they cause apoptosis and destruction of the cell that it's attached to. So that kind of sounds like it's an effector function, right? So whenever two answer choices sound similar and they are definitely in accordance with one another and there's not really much of a difference, they're most likely both wrong. And how about E? It will undergo clonal expansion. Well, so when these types of cells become activated, they do actually undergo clonal expansion. So there's actually 3 choices that say, okay, it's going to be activated. And there's one choice, right, choice C, that says it's not going to be activated. So if you had to just go on pure test taking skills, which one out of those 4, right? We've eliminated choice B because that's only for B cells. Which one, A, C, D, or E, is the one most left out of the group? That one would be C, right? Because it's not activated, it's not able to carry out an effector function, such as like releasing granzyme or undergoing clonal expansion or something along those lines. So let's talk about why it actually is C. So you actually need 2 signals in order to activate both T and B cells. The first signal needs to be the MHC complex with the antigen bound. And then the second one needs to be a co-stimulatory, whether that's B7 or something along those lines. If you only get one of those signals without the co-stimulatory signal, the cell will not destroy itself, but it will undergo anergy. They highlight this fact a lot. Sometimes it goes overlooked by some students, so I would definitely just keep this in your mind. If a cell's in the periphery, and it binds only to one signal molecule, not both signal molecules, it will undergo energy. Great job on that one. That was a little bit more of just a pure memorization thing, but I'm glad we were able to explore some of the test-taking skills. Let's move on to the next question. Okay, so this question is pretty high yield. I mean, everything is high yield, but this is very, very high yield. You will definitely see one of these types of questions on your exam. So what I want you to do is approach it like it's the exam. I want you to read over, do the method, right? Read over the last line, read the question, read the answer choices, and then read the rest of it. Okay, so in your head, you should have a clinical picture, right? Just chronic joint pains, feeling tired. The pains are in her hands and her knees. There is symmetry, which is very, very important in terms of making a differential. When she takes NSAIDs, there's not really too much relief. And her arthralgias are worst in the morning and improves with use. So we have symmetrical joint pain that affects the hands and knees, and it gets better with use. So which one of those diseases that we know, right, like lupus, rheumatoid arthritis, osteoarthritis, gout, pseudogout, septic arthritis, psoriatic arthritis, any of those, which one fits this description the best? Okay, and you should be saying rheumatoid arthritis, right? They're going to give you some things that will give it away. They might give you a histological description of it. They may just say, like symmetrical joint pain that improves with use, as we see in the question here. As long as they don't say that the dips, right, the distal interphalangeal joints are involved, right, because that's never involved in rheumatoid arthritis as far as the questions go. This is how they're going to be testing it. So now you need to know which antibodies would confirm the diagnosis. So you need to know which of the autoantibodies would confirm the diagnosis. So we have anti-mitochondrial antibody. What does that do? What's that for? That's for primary biliary cholangitis. Does that show up with this clinical picture? No, it doesn't. How about anti-IgG? Do you know another name for anti-IgG? I bet you do. So anti-IgG is also known as rheumatoid factor. So rheumatoid factor is actually an IgM immunoglobulin that targets IgG. And that's found in a couple conditions. It's not super specific for rheumatoid arthritis, but it does have rheumatoid arthritis under its umbrella. So it's not the most specific antibody for it. That would be actually anti-CCP. But this does have rheumatoid arthritis under its umbrella. How about anti-centromere antibody? Well, that's for CREST syndrome, right? Limited scleroderma. Does that present in this way? No. The mnemonic for CREST is CREST, C-R-E-S-T, calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. None of them are seen here, not even one. So that's not the answer. How about anti-double-stranded DNA? Well, that's actually very, very specific, but it's specific for lupus. How about anti-nuclear antibodies? Sometimes it shows up in shorthand as ANA. So that's not very specific for anything. It's sensitive, right? It's mainly associated with lupus, but it could be in a couple other conditions as well. Either way, like we said, this clinical presentation in particular is presenting like rheumatoid arthritis. So the only one that rheumatoid arthritis falls under would be anti-IgG, also known as rheumatoid factor. And don't forget that rheumatoid factor is actually an IgM immunoglobulin that targets IgG. So this is a little bit of a longer question, and we see already that there's some sort of serum analysis thing going on with immunoglobulin levels. So I want you to just read over this on your own, take a little bit of time, try to really understand what's going on here. If this isn't your strong suit, this is the time to learn it. Okay, so if you would have followed the method, you would have already seen that this is all about immunodeficiencies before you actually read the full question. So different types of immunodeficiencies, they're trying to highlight what's the difference between them, right? How do you distinguish between them? And they give you one particular case, and they want you to say, okay, it's not like these other cases. So we have an 8-month-old infant brought in today because of a cough. His temperature is 101.2 degrees Fahrenheit. He has oftentimes required multiple courses of antibiotics for several respiratory infections over the past few months. There are normal levels of CD4 and CD8 cells, and the analysis shows all the immunoglobulins are decreased. So what condition is this? What has normal T cell levels but diminished immunoglobulins? And in case you don't know, we're going to go through the answer choices, and when we get to the answer choice, we'll highlight it. So severe combined immunodeficiency. The way I remember this one is when they say combined literally just means T cells and B cells affected. But the question states, normal CD4 and CD8 cells. So that can't be the right answer. How about Cheday-Higashi? Well, Cheday-Higashi is a mutation of the LIST gene, which is lysosomal trafficking protein, and that causes a microtubule dysfunction. So you don't have phagolysosomal fusion, and this leads to a whole slew of issues. So common presentation for this one would be like a silvery hair, paler skin, because you have defective melanosomes, right? You have decreased melanin, and thus you have like not true albino features, but skin's overall lighter and the hair's lighter. You also have defective secretions, pancytopenia, and you have neurologic issues. So does that sound like the presentation that we have currently? No, that doesn't sound like it. Then we have ataxia-telangiectasia. So how does ataxia-telangiectasia present? Well, it's usually somebody who is prone to falling and infections, right? Ataxic means, unsteady. So one really high-yield fact about ataxia-telangiectasia is that you will have decreased levels of IgA, IgG, and IgE. So the mnemonic I use is that with ataxia-telangiectasia, the gene that's mutated is ATM, and you have to be a certain age to operate the ATM, right? So if there's a problem, that means you're too young. So you're going to have decreased age, right? IgA, IgG, and IgE. So for proper functioning of ATM, you need to be at an older age. And it's not functioning in ataxia-telangiectasia, so you're at a younger age. So you have decreased levels of A, G, and E immunoglobulins. So what does that also imply? That means you have normal M. You have normal IgM. And we see just from the numbers, IgM is 2 milligrams per deciliter, and that's low compared to the normal. So that can't be the answer either. How about Bruton agammaglobulinemia? Well, besides being a mouthful, the problem there is Bruton tyrosine kinase. So that's what's messed up, and this is like a fun factoid you have to know about it. Messing up BTK, or Bruton tyrosine kinase, actually messes with the differentiation into the pre-B cells from the pro-B cells. And if you aren't able to get to that point where you have pre-B cells, right, because you're not able to mature due to this BTK mutation, you're going to have decreased levels of all immunoglobulin because you're not going to have plasma cells. So this is specific to B cells, and it's going to have decreased immunoglobulin production globally, and it will not affect T cell levels, which is exactly what we see here, right? Decreased immunoglobulin across the board, but the T cell levels remain the same. So the answer is D, Bruton agammaglobulinemia. But let's also talk about chronic granulomatous disease. So chronic granulomatous disease is a mutation of NADPH oxidase, which is part of the oxidative burst killing infectious organisms. So if you don't have the oxidative burst, your innate immune system will not be as fully functional, and as such, you're going to be prone to infections, specifically with Staph aureus, Aspergillus, Candida, basically anything with catalase, which if you remember from Sketchy, would be those bugs and a couple others. Right? If you can't kill something, your body tries to wall it off. And the way that it walls it off is through granulomas. So that's why it's called chronic granulomatous disease, because you can't clear these infections. You can't carry out oxygen-dependent killing of these organisms. Right? For the non-catalase positive organisms, you could actually kill because they produce some baseline level of hydrogen peroxide, and that's further down in the pathway than NADPH oxidase. So you could kill those, but you can't kill Staph aureus, Aspergillus, and Candida because they all have catalase. Good job, that was a little bit of a tougher one. So let's look at this question. Let's do the method together. We'll start with blood work, right? Blood work shows that the patient is anemic, has a weakly positive ANA, right? That's anti-nuclear antibody, and has a positive screening test for syphilis. Which antibody is the most specific for this patient's condition? A, anti-SCL70, B, anti-IgG, C, anti-microsomal, D, anti-Me2, E, anti-Smith. So let's quickly go over what, in your head you'll be doing this automatically come test day, but let's just quickly go over what each autoantibody is associated with. Anti-SCL70 is associated with diffuse scleroderma, right? The type of scleroderma that involves the viscera, the organs. B, we talked about before, that's mostly correlated with rheumatoid arthritis, but it's not super specific. C, antimicrosomal, that actually correlates with Hashimoto's thyroiditis. D, anti-Me2, correlates with poly or dermatomyositis. And E, anti-Smith, or anti-double-stranded DNA, corresponds with lupus or SLE. Let's read over the rest of the question. You are presenting a patient to your attending physician. The patient complains of a swollen wrist, facial rash, and fever. Upon examination, oral ulcers are present. And we know about the blood work already, the ANA, and the VDRL. So you could do process of elimination again, but you should have a little bit of a better understanding when it comes to these types of questions now. Let's just kind of delve on into it. What does this clinical picture resemble? Right, swollen wrist, right? The wrist is a joint, so they're just saying you have either edema or a swollen joint from an inflammatory condition, which is most likely the latter in this case. A facial rash. You have oral ulcers, patient's anemic, ANA and positive VDRL. So all this points to lupus. So the answer would be choice E, anti-Smith antibody or anti-double-stranded DNA. Lupus can present with joint pain, that facial rash when you go out into the sun, right? It spares the nasolabial folds, but it kind of goes on the cheeks and the nose. You can have oral ulcers. The patient's anemic because in this case, the anti-double-stranded DNA or anti-Smith antibodies that target the cells that are circulating throughout the body causes the anemia. Patient has a weakly positive ANA. Well, we know that that's not specific for a lot, but it does bring us towards lupus because that is one of the conditions in which ANAs are present. Positive screening test for syphilis. Well, this is an interesting one, and I'm sure you guys have heard of it maybe at some point, and if you haven't heard of it, it's definitely worth committing to memory. You could get a positive VDRL in lupus patients because lupus patients actually produce 3 types of autoimmune antibodies. They produce antiphospholipid, also known as lupus coagulant. They produce anti-double-stranded DNA, or anti-Smith, and then they produce anti-cardiolipin. And cardiolipin actually has similar antigen presentation as the spirochetes in syphilis. So there is a little bit of a cross-reactivity there, and the test will actually come back as positive, even if the patient doesn't really have syphilis, they just have a lupus. Okay, and another fact to know is that the antiphospholipid, or the lupus coagulant, could cause recurrent spontaneous abortions or miscarriages. It does actually the opposite of what the name says. So in the test tube, it causes anticoagulation effect, but in the body, it actually causes a hypercoagulation effect. So you throw more clots, you cause thromboses, right? And that's exactly what happens in pregnant women. The vessels going to and from the placenta thrombose. There's a clot there that's present, it cuts off supply, and it causes fetal distress and eventual abortion, unfortunately. So if you see recurrent abortions, lupus should be on your differential. Okay, so definitely try to commit that clinical picture to memory. They probably won't show you every single one of the symptoms, but they'll give you 2 or 3 really high yield ones that are kind of unique to lupus in general. Okay, so let's move on to the next question. So I want you to do this question by yourself. You probably don't even need me for this one. You're going to knock it out of the park with our previous discussions. So we have a 6-month-old girl present with diarrheal symptoms and is positive for Candida infection. She has a history of recurrent infections. Blood work reveals diminished T cell and B cell concentrations. What's the most likely cause of this patient's condition? So we know it has to affect both T and B cell concentrations. So typically the other answer choices that the boards like to give you when it comes to questions like this are going to be other conditions. So when you're going through these types of answer choices, I want you to think, what is that condition? So DNA repair defects in the setting of an immunodeficient individual, that's most likely going to be ataxia telangiectasia. Right, it could be a few other things, but for majority of the case, it's probably going to be ataxia telangiectasia because that has to do, ATM protein has to do with DNA repair. Right, because it recruits BRCA and a couple other complexes as well. We won't get into that here, but just know that it's probably talking about ataxia telangiectasia. Is this the presentation of ataxia telangiectasia? Correct. You should be saying no. How about B, deficiency of NADPH oxidase? Well, we talked about this one before. This is just chronic granulomatous disease. So we should be seeing catalase positive organisms. Do we see that here? Yeah, we do. We do see that here. Right, Candida. Candida's catalase positive. But here's the other thing. Chronic granulomatous disease, if you remember from just a few questions ago, I said it affects the innate immune system. Right, it affects the innate immune system because it messes with the oxidative burst. So it has nothing to do with T and B cells, it has to do with the oxidative burst. And here we see diminished T and B cells, so that's how you eliminate choice B. How about deficiency of adenosine deaminase? They could also say ADA, but most likely they'll say adenosine deaminase. Okay, so some of you are probably saying yes, some of you are probably saying no right about now. So this actually is the correct answer. Right, so C, deficiency of adenosine deaminase, is actually the correct answer. And that's because when you have that enzyme missing or malfunctioning, you have a buildup of adenosine. And adenosine in high concentration is toxic, especially to lymphocytes, right, T and B cells. This is actually one of the most common causes in severe combined immunodeficiency. So ADA deficiency, I want you to associate with T and B cell depletion, and therefore you're going to get recurrent infections. Let's just finish out the rest of the answer choices. Aldolase deficiency. No, that has to do with the whole fructose metabolism pathway. It has nothing to do with anything immune-related. How about chromosome 22 deletion? Well, we talked about this one before. This is DiGeorge syndrome, and we know that typically presents with low calcium, spasms, missing thymus, low T cells, normal B cells. Is that the presentation that we see here? No, because it has diminished T cells and B cells, right? If it was just diminished T cells and she was having spasms and maybe they did some sort of imaging and there was no thymus present, right? They usually say, quote, the absence of a thymus or the thymic shadow. That would be DiGeorge syndrome, but not in this case. Okay, so we only have a few more questions to go. So if you're getting a little fatigued, maybe pause the video, go splash some water in your face, grab a cup of tea, and then come right back because we're going to hit this thing hard, okay? All right, so let's get into this one. There's 1 or 2 lines. You could read through the whole thing. I'll read it with you, and then we'll answer the question together. So a man who immigrated to the United States comes to a primary care clinic to get his PPD read. His PPD result is positive even though an X-ray of his chest is normal. The patient is given isoniazid monotherapy in agreement with current guidelines. The underlying response involved in PPD testing is also responsible for which of the following reactions? A. Arthus reaction. B. Urticaria. C. Graves' disease. D. Rheumatic heart disease. E. Contact dermatitis. Okay, so there was a similar question in the dermatology video. So if you've watched that, you might have a little bit of a leg up. But for those who didn't, don't worry, we're going to go through it. So whenever they ask you these types of questions, what kind of reaction is it? They're typically talking about hypersensitivity, right? A hypersensitivity response. So there are 4 of them. There's like subdivisions in each one, but that's a little bit out of scope for step 1 in complex level 1. So let's go through all of these and we find pretty much which one will match up with PPD. Let's just go through first and then we'll talk about PPD. So is the Arthus reaction a type 1, 2, 3, or 4 hypersensitivity reaction? Yeah, so an Arthus is a type 3 reaction, right? You can get joint pain, redness, that kind of stuff. It's really just deposition of immune complex with antigen. And it circulates through the body, it deposits somewhere, and it causes an inflammatory process at that area. Urticaria. So urticaria is like the generic allergy, right? That's the one where you get wheals. You could eventually get anaphylaxis. You get edema. That's a type 1 hypersensitivity reaction. What about Graves' disease? So that's autoimmune antibody that causes activation of TSH receptors, right? So Graves' disease is technically a non-cytotoxic version of a type 2 hypersensitivity reaction. How about rheumatic heart disease? Okay, so that actually is a cytotoxic version of type 2 hypersensitivity reaction. The M protein is similar in its antigen presentation essentially to that of tropomyosin and myosin and other cardiac components. So on occasion, it could cause rheumatic heart disease, which is really just autoimmune antibodies being produced. And it's a cross-reactivity response. It's autoimmune antibodies that are targeting the M protein, but in actuality, it has a cross-reactivity and it does a little bit of damage to the cardiac components. So that's why it affects the heart. How about contact dermatitis? Yeah, so contact dermatitis is different than allergic dermatitis or atopic dermatitis. So contact dermatitis is like the nickel allergy. It's actually a type 4 hypersensitivity reaction. Okay, and how about PPD? So when you inject a little bit of that like purified protein derivative, right, the tuberculin protein derivative, there's an induration that occurs, right? It gets a little bit of like an edematous reaction, it hardens a little bit, and that's from previously sensitized T lymphocytes. Even if you knew nothing about PPD, aside from having it done before, you're going to go back into the clinic 1 to 2 days later, right? And they recheck you 2 days later, which means it's not an immediate response, it's a delayed type response. And the only response that has the name delayed is a delayed type 4 hypersensitivity reaction, right? So PPD is a type 4, and we also said contact dermatitis is a type 4. So choice E, contact dermatitis, is going to be the answer for this one. Congratulations if you got that one. Let's move on to the next question. Okay, So let's talk about this one after you've already done it. So I'm going to give you about 10 or 15 seconds. You can pause the video if you need longer, and then we're going to go into it. All right, so this question is asking for the most likely diagnosis. And this person has, pruritic red eyes that began a week ago. She had a diarrheal illness a few weeks ago. She has pain in a knee that appears swollen and red, so it's inflammatory. There's no rheumatoid factor, but she is positive for HLA-B27. So they love to test this one too. HLA-B27 is associated with those 4 conditions, right? There's a mnemonic for it, PAIR, P-A-I-R. So the mnemonic PAIR stands for psoriatic arthritis, ankylosing spondylitis, IBD-associated arthritis, and reactive arthritis. So we know it's going to be one of those 4, and some of them show up in the answer choices. The ones that don't, you could just rule out, right? So we're really just left with reactive arthritis, IBD-associated arthritis, and ankylosing spondylitis. So what do we know about reactive arthritis? Well, there's a mnemonic for that one too. That one is can't see, can't pee, can't climb a tree. So what the hell does that mean? Well, you can't see because it's affecting your eyes. You can't pee because it affects your urethra, it causes urethritis. And you can't climb a tree because it messes with your joints, which presumably would be used in climbing a tree. So if you see that triad, it's most likely reactive arthritis. Do we see that here? Well, we don't see urination issues, but we see the other 2, so that's most likely going to be correct. But let's say we're not sure still. Let's evaluate the other answer choices. IBD-associated arthritis. So does this patient have IBD? Well, she had diarrhea a few weeks ago. Does that mean she has IBD? No, it doesn't. So this is one of the points I wanted to bring up. I didn't mention it for reactive arthritis intentionally because I wanted to see if you knew it. So reactive arthritis it's usually precipitated by a GI infection, right? So if you have a diarrheal illness a few weeks ago, right, fever, diarrhea, maybe nausea, chills, whatever, and you get over it, right? This patient doesn't have those symptoms anymore. She just has the joint pain and the pruritic red itchy eyes. So she has eye problems and joint problems after a diarrheal episode or diarrheal illness that's since resolved, and she's HLA-B27 positive. You're thinking reactive arthritis over IBD-associated arthritis. Especially because IBD-associated arthritis, you typically don't have that reactive arthritis triad that we were talking about. You just have the joint pain. And you can also have other symptoms, but we'll cover that when we get to GI. How about ankylosing spondylitis? So ankylosing spondylitis localizes pretty much around the axial skeleton, right? It really is a condition of the spine itself. You get that bamboo spine on X-ray and radiograph, and it's typically associated with older men, right? This is a 42-year-old woman, so she's not really the ideal demographic for it. I mean, it's still possible. If you see it on boards, you want to consider it, but it doesn't present with that sort of triad. So let's move on to the next question, and this will be the final question for this video. But don't worry, we will have plenty more in due time. We're going to be pumping out content as much as we could. We're going to try to get you that board score that we know you deserve. All right, let's tackle this final question together. Let's start reading from where it says there are fragments. Okay, so there are fragments of degenerating cartilage present in the joint. Joint aspiration reveals low white blood cells and no organisms. What's the most likely diagnosis? We have osteoporosis, rheumatoid arthritis, psoriatic arthritis, osteoarthritis, calcium pyrophosphate deposition disease. That's also known as pseudogout. Now we can read the rest of it. An obese female complains of unilateral knee pain that gets worse throughout the day. Physical examination does not reveal swelling, erythema, or effusion. Imaging reveals a bony protuberance attached to the medial tibial plateau. And then we read the last part. There are fragments of degenerating cartilage present in the joint. Joint aspiration reveals low WBCs and no organisms. So what is this? We can tell by the demographic they threw in obese female for a reason, right? They also said unilateral knee pain, which means that's another way of saying it. There's asymmetric knee pain or asymmetric arthritis. There's no swelling, erythema, or effusion, so it's not a inflammatory or a septic condition, really. It could be mild inflammatory because it's kind of a sliding scale, but it's not going to be one of those really big inflammatory conditions or septic condition, right? Not like a septic arthritis, and also most likely not something like rheumatoid arthritis for a few reasons. The first being that there's no swelling or erythema, that's just one knee and it's not symmetric. And then we get bony protuberance that's attached to the medial tibial plateau. What is the bony protuberance called? Well, it's an osteophyte, right? A bony outgrowth or a bony protuberance, especially along joint planes or a joint line, that's an osteophyte. So you have osteophytes and you have fragments of degenerating cartilage that's present in the joint. So what is that usually hallmark for? So we have asymmetry, non-inflammatory, with osteophytes and degenerating cartilage within the joint. There's no organisms, or low WBCs on the aspiration. Would it be osteoporosis? No, it wouldn't be osteoporosis. Right? That doesn't really make sense because osteoporosis, that's more of like vertebral fractures. That's more of like just bony fractures in general. We don't see fractures here. How about rheumatoid arthritis? Well, we kind of already ruled that out in our discussion earlier. How about psoriatic arthritis? Right, there are a few ways that psoriatic arthritis could present. There's different subtypes, but largely it is still an inflammatory condition, and we don't see really any sort of inflammation. We don't see any of the other hallmark signs of like psoriatic arthritis. Would be something like nail pitting and psoriatic plaques. We don't see any skin lesions on this woman, so we could rule out psoriatic arthritis with some confidence. How about osteoarthritis? Yeah, so osteoarthritis, that's a pretty good answer choice for this one because it's an obese female, which is a risk factor, right? The heavier you are, the more proximate the joint will be, the more stress placed on it, so you're going to have more bone on bone. Also bony protuberance, you see osteophytes with osteoarthritis typically. Degenerating cartilage present in the joint is usually a hallmark for osteoarthritis as well. And it's a non-inflammatory condition, really. Like there's no autoantibodies causing, paniculitis, which is the case in rheumatoid arthritis. It's unilateral, it's asymmetric, and they can also say that it gets worse with use. That's the only other thing they can really say that will give it away, is that it gets worse with use. They didn't say it in this question, but it could be said in other questions instead of one of these other facts that I gave you. Well, let's look at calcium pyrophosphate deposition disease, also known as pseudogout. It's kind of in the name. It looks like gout, it smells like gout, it tastes like gout, but it's not gout. This is just a different type of crystal being deposited. This is actually calcium pyrophosphate being deposited, and it has a high correspondence with hemochromatosis. But just like gout, it would present as an inflammatory condition. We don't have that swelling and erythema and possible effusion, right? So that's less likely compared to osteoarthritis. So osteoarthritis is our best choice, and that happens to be the answer. And just to repeat, whenever you see asymmetrical joint pain, it's non-inflammatory, there's no organisms, there's osteophyte formation, and there might be a little bit of broken cartilage or bone within the actual joint, then I want you to think osteoarthritis, especially in an obese female or an obese male. Okay? So I know that was a lot, but we got through it. Hopefully you came out knowing more than you went into this video knowing. You're going to kill the test. Don't worry about it. We're going to keep doing this, and we're going to have a ton of questions. You're going to see so many questions that when you sit down for your step or your complex, you won't even feel a little bit nervous. You'll actually probably feel more like, I just want to get this over with because I just know all these questions already. We're going to try to present everything that we could. So if you think we left something out or you have a particular weakness, feel free to email me. Feel free to comment on the video. And if you want to show any support, please like, comment, subscribe. The subscriptions is probably the most helpful, but whatever you guys want to do, we appreciate any and all forms of support. All right, well, thank you for joining me, and I will see you in the next episode of QuickSTEPs.